Hi everyone, I am Dr. Emad Magdy, lecturer of nephrology at Mansoura University. I will speak to you today about one of the important diagnostic tools in the renal medicine and in renal disease diagnosis, which is the kidney biopsy. I have some objectives in this lecture, those listed to define an important tool for renal disease diagnosis, which is the kidney biopsy. I will take hint about the procedure and the instruments. Why? Because this will help us to know about the indications and the justification to do the biopsy, indications and the contraindications, and this last objective is the most important one, to know about the patterns of glomerular injury and how can the histopathology be related to the clinical presentation. So which histopathological change will be presented with which presentation. This is the most important learning objective in this lecture. Okay, let's start with the first one. This man, Richard Bright. This is the father of nephrology, or he is the father of nephrology. At the 18th century, described firstly the Bright's disease, which is a historical classification of kidney diseases that would be described in modern medicine as an acute or chronic nephritis. It was characterized by swelling, presence of albumin in the urine, and was frequently accompanied by hyperpressure and heart disease. He described 25 cases of edema, which he attributed to the kidney disease. Symptoms and signs included inflammation of serous membranes, hemorrhages, apoplexy, convulsion, blindness, and many of these cases were found to have albumin in their urine, detected by spoon or candle at this time, and showed striking morbid changes of the kidney at autopsy. And this is the anatomy lesson in 1632 by Dr. Nicholas. So the first knowing about the kidney disease, the Bright's disease, in the first half of the 20th century, 90% of the nephropathies were unknown to nephrologists. There is no nephrology and pathologists, and they would have remained so without the use of renal biopsy. Only in 1951, the potential importance of renal pathology was underlined by two Danish investigators in a study where the renal biopsy had allowed determination of the cause of the acute renal failure in the majority of patients which undergone dialysis. So what are the targets of the nephrologist when prescribing or requesting a kidney biopsy to the patient? Is it to know, just to know the pathology, just to know the disease, just to know the diagnosis? It's not the right justification of the biopsy. Why? Because the biopsy is an invasive technique. So I should be justified to do the technique. I should be in a situation that I can guarantee that the patient will benefit from the result of the histopathological examination. And those are the research, how the research told us that the renal biopsy helped the nephrologist to how much. The renal biopsy results alters clinical diagnosis in about 25 to 50% of cases, and the guide treatment by determining the reversibility and the activity of the lesion, and may change the therapy in 30-40% of the patients. What does it mean? The reversibility means that when I am facing a patient with renal problem or deterioration of kidney function, the first question comes to my mind: is this pathology can be reversible or not? Because if it is reversible, if it have a specific treatment, I can save the patient kidney for life. And the activity of lesion, what's the meaning of activity of lesion? The activity of lesion we will describe in the next slides. The patterns of injury, we have tissue changes, which is acute, active tissue changes. It means that those are recent changes in the tissue. I can reverse these changes with the treatment and save the patient kidney. But I have on the opposite side the chronic lesions. Chronic lesion means that the tissue is fibrotic. There is no hope to regain the tissue back, and this is very important decision to the nephrologist when treating his or her patient. Okay. Also, it can predict the prognosis by assessing specific pathologic features and the extent of changes and validate outcomes. So when used as an endpoint in clinical trials, so again, what does it mean? That one of the most important questions the patient will ask you when having a deteriorated kidney function: what is my prognosis? Will I need renal replacement therapy? When? Will I need to be on the hemodialysis for life? Can I have kidney transplantation? All these questions related to the prognosis is very important one. Lastly, it reveals pathogenesis by studying the molecular and the cellular mechanisms of renal disease and open new horizons and the novel therapies. And this is why we study the micro architecture of the tissue, the changes. I know that this disease is an immune complex disease. When I see the immune complexes, antigens and antibodies precipitated in the tissue and come after around its inflammation, this inflammation causes damage. This is how can I know about that before the biopsy? As I told you, before 1951, there is no complete knowledge about the nephrology disease. Why? Because we don't characterize the tissue till this moment. Just the Bright's disease or just a description of finding in autopsies. It's not determined pathologies and determined diseases. Come to the third or maybe the second objective. What are the indications and the contraindications? So built on this manner I discussed in the previous slides, what are the indications of doing renal biopsy or prescribing renal biopsy? Again and again, the indications are related to decisions in management and decisions in treatment and decisions in prognosis of the patient. So if the biopsy will benefit me in determining the diagnosis, and this diagnosis have a specific treatment, so I can reverse the condition, I will order biopsy. If the condition is so severe, I will order biopsy. If the condition I need to know about the prognosis, I need to order biopsy, but not for all the patients. Just the patients who I cannot answer these questions without the biopsy. So the presence of elevated serum creatinine with decreased glomerular filtration rate, especially in undiagnosed acute kidney injury, is an indication of biopsy. In acute tubular necrosis not resolving after 3-4 weeks. Why after 3-4 weeks? Because we know from the natural history of the acute tubular necrosis that the acute tubular necrosis have no specific treatment, just a conservative measures. So the biopsy will not change my mind in the treatment. And I know from the natural history, from the natural course of the disease, that the kidney tubules will regain after 3 to 4 weeks. So if the pathology extend or the kidney function not regained after the known period of resolution, so here I will order biopsy to know the prognosis of the patient, because the tubular necrosis may be accompanied by a cortical necrosis, and this cortical necrosis is a chronic lesion, and the patient will pass to chronic kidney disease and will not regain his or her kidney function. The presence of hematuria, asymptomatic or symptomatic gross hematuria, isolated or associated with subnephrotic proteinuria, especially when the hematuria is combined with acute renal failure, it means the nephritic syndrome. The nephritic syndrome, as we will mention in the next slides, is related to certain types of glomerular patterns, which is all active patterns, and these active patterns may imply certain treatments to reverse the condition. So the nephritic syndrome, as a presentation, nephritic syndrome is hypertension, renal impairment, hematuria, proteinuria, non-nephrotic range proteinuria. This is an indication for kidney biopsy. The nephrotic syndrome, proteinuria more than 3.5 grams per day, hypoalbuminemia, edema, and hyperlipidemia is a mandatory indication of biopsy in adults and in children with atypical features. Why? Because in children 90% of the children's, the biopsy result will be minimal change disease, and again this minimal change disease have no specific treatment except in the resistant cases or the cases with atypical features. So if I know the treatment before the biopsy, so I will not do biopsy. I reserve it to the situation of follow-up, not the diagnosis. Should be performed in systemic disease and renal dysfunction. As an example, if I have a patient with suspected small vessel affection, like rashes, skin rashes, arthritis, GIT symptoms, pulmonary symptoms, all these are systemic disease which can affect any organ of the body which have small vessels. The kidney is one of the bodies in the body have small organs of the body have small vessels. So any disease which will affect the small vessel, like the small vessel vasculitis, need specific treatment, and I can diagnose it through the kidney biopsy. So those are the indication. This is another the same in another manner: the nephrotic syndrome, the acute kidney injury, the systemic disease with renal dysfunction, and non-nephrotic proteinuria, and isolated microscopic hematuria, but should be persistent. And those are the sub conditions. What are the contraindications of doing renal biopsy? As an invasive maneuver, I will describe in the next slides how the procedure, slight hint about the procedure. As an invasive maneuver, the kidney biopsy should be reserved and should know when to not do biopsy. We have multiple contraindications. Not all of them are absolute. Some are absolute and some are relative according to the circumstances of the patient. But the absolute, I cannot do biopsy with uncontrolled bleeding disorder or uncontrolled blood pressure, because this will increase the risk of complications from the biopsy. Bleeding from the biopsy may be nephrectomy, maybe even more than internal bleeding and death. So I don't have to do biopsy whatever the cause in a patient with uncontrolled bleeding disorder or uncontrolled blood pressure. But all the other contraindications may be relative or absolute, like the solitary kidney, because if I have the patient have a solitary kidney, so any problem or any complication in this biopsy will harm him a lot. Multiple cysts, perinephric abscess, renal neoplasm, obesity, uncooperative patients. Why? Most contraindications are relative rather than absolute, and the clinical circumstances that necessitate urgent renal biopsy may be overridden except for uncontrolled bleeding diathesis. One thing I'd like to mention about the renal biopsy, we know that all the biopsies is the better or the best tool for diagnosis of malignancy. It is not that way in the kidney, because the kidney biopsies is not preferred in the kidney tumors except if the tumor is too small and too localized and too reachable by the ultrasound or CT. So I can do this, but it's not the routine. The kidney neoplasm is not a routine indication for doing kidney biopsy. In advanced kidney disease and ultrasound imaging of reduced kidney volume, the renal biopsy is generally contraindicated. Why? Because it will not benefit me anything. It just give me a fibrotic tissue. So no decision change in management or in prognosis of the patient. So the patient preparations before the procedure, I should do renal imaging and get confident that I have two normal sized, unscarred, unobstructed kidneys, because those are the diagnoses which I can benefit from the renal biopsy. Blood pressure, diastolic blood pressure should be less than 90. Urine culture should be sterile. Coagulation status, I should check the platelet count, the prothrombin time, the bleeding time, and the clotting time. And a very important idea is to stop any drug which cause coagulation problem, or anticoagulant, antiplatelets, aspirin, clopidogrel, or warfarin for 7 days before biopsy. Non-steroidal and subcutaneous heparin 24 hours before doing the biopsy. And this is the workup in another diagram. The procedure in this this is the diagram of the kidney, and as we see here, the cortex, the kidney consists of cortex, outer medulla and the inner medulla. You see here in the cortex the nephrons, the glomeruli, and the origin of the tubules, and the renal vasculature all are presented in the cortex. So my target is to take a core of tissue from the cortex, not from the medulla, because as you see, the medulla is a site of tubules and vessels only, and I don't have glomeruli, and the glomeruli is my main target in biopsying the kidney. So I should take the biopsy from the medulla, from the cortex. I should have an ultrasound probe monitor for the ultrasound, and ultrasound probe to determine the site of the kidney, and then the biopsy needle, and this is the automated gun biopsy device or biopsy needle. I will combine with this a video for the procedure of kidney biopsy itself to be more logic, and this is the idea. Those were the old needles for the kidney biopsy, manual gun, but we now have the automatic or automated gun biopsy, and this is the cortex, which is the target. This is by the ultrasound, and this is by the CT. If I enter, this is the needle, my needle under the ultrasound, and this is the kidney. So I will direct my needle to the lower pole of the kidney, away from the vital structures, so avoid any injury of any abdominal organ, intestine or spleen or something like that, in the lower pole of the kidney. And this is the kidney capsule, so I will use the gun on this cortex, and this is CT image to again from the lower pole of the kidney from the cortex. The gun is advanced to the capsule and fired to the lower pole of the left kidney. This is the gun, this is the gun, the needle, and this is the kidney, and this is the left kidney lower lobe. After taking the loop, one of the very important things I would like to do in the renal biopsy room is to evaluate the core of tissue you take from the kidney. This, because I can take the tissue from the perinephric fat, I can see glomeruli like this one. This is a core of white tissue. There is no glomeruli. Where is the glomeruli? Those are the glomeruli. Those are the glomeruli. Those red dots are the glomeruli. So I should 1, 2, 3, 4, 5, 6, 7, 8, and this 1, 2, 3, 4, 5, and those multiple glomeruli. Here I can't count anyone because I have a criteria for the adequate kidney biopsy. An adequate kidney biopsy should provide samples for immunohistology and electron microscopy. I need at least 10 glomeruli. A typical diagnostically useful biopsy sample will contain 10 to 15 glomeruli, cortex and the medulla, 1 and 2 glomeruli for the electron microscope, 3 and 5 glomeruli for the immunofluorescence, 6 glomeruli for the light microscopy, and 10 glomeruli if the biopsy from renal transplant kidney, not a native kidney. Okay, and this is how to count the glomeruli. If I take the core without glomeruli like this, or without sufficient glomeruli, I can take 2 or 3 cores before discharging the patient from the procedure. And then we'll come to the stains. The kidney sample or the renal sample should be stained with multiple stains. Why? Because I have different structures in the glomerular capillary. I have membranes, and I have mesangium, I have cells, I have tubules. So each stain will discriminate us some structures and some changes which help us in the final diagnosis. We have those stains, but the most common is the hematoxylin eosine, periodic acid Schiff, silver stain, and mason trichrome stain. Those are the most important. The hematoxylin eosine is the stain responsible for describing the cells. So if you see a slide stained with hematoxylin eosine, you will find the nuclei and cells, Those are the most important structures you will find in the hematoxylin eosine. In periodic acid Schiff, it will discriminate very good the basement membranes and the mesangial matrix. Here you can see the membranes. I will show you a slightly more large photos. The trichrome means three colors. It will stain the fibrosis with the blue color, and this is a very important to see the trichrome stain on the low microscopy, to know light microscopy, low power, to know how much of the tissue is fibrosed. And this silver stain is the black and white. This is the negative of the pus stain. So I can show the basement membrane and the mesangial matrix in black and all the other in white. And so again, it will help us to discriminate the basement membrane and the mesangial matrix. It changes very well. And those are the examples. Okay, here we don't see anything like except cells and nuclei, and this is the hematoxylin and the eosine. Here the basement membranes is very determined. This is the Bowman's capsule, this is the glomerular capillary basement membrane, and this is the tubular basement membrane. All the membranes are evident. So this is the periodic acid Schiff stain. This is the negative, black and white. So this is the mesangium is black. The glomerular capillary membrane, we can define it very well. We can draw it, and this is the Bowman's capsule. All are black and white. This is the silver stain. This is the trichrome stain. We have three colors: the red and the blue and the orange. And this red is the determinant of the fibrosis. So I can know this is the trichrome stain. So we have hematoxylin, pus, silver, and trichrome stain. Sectioning and powering. Firstly, I should see the core under this is the light microscopy, under the low power, then high power. Why? Because I'd like to describe a very important terminology you should know in the kidney biopsy. Under the microscope, first a low power screening examination of the specimen should be carried out. This will give an idea about areas of defect and will also help in localizing the defect. Is it in glomerulus, tubules, and interstitium or blood vessels? In addition to size of lesion, the distribution of lesion is also important from the pathology point of view. So I should see, you can name the the low power of the light microscopy is as a towering view. I should have a towering view for all the specimen. Why? Because it will help me to determine this very important terminology in the histopathology diagnosis. Is any change is diffuse or focal? The diffuse change means that this is change occurring in all the glomeruli. So I should see all the glomeruli under the low power light microscopy. But the focal change are changes occurring in few glomeruli only. Then pass to the high power of the glomerulus itself. I have global change and segmental change. Global change, the whole glomerulus is involved. Segmental changes, only some parts of the glomerulus is involved. Why I exhaust you with this terminology? Because we will find when you study all the diseases of the kidney, you will find in the histopathology the diffuse, global, focal, segmental, global change, global glomerulosclerosis, focal, diffuse glomerulosclerosis, global glomerulosclerosis, focal change, segmental change. So you should be familiar about the terminology. So those are under the light microscopy, and light microscopy low power, and this light microscopy high power. This for a scene for all the glomeruli, but this for a certain glomerulus. And this is a simple representative of this. This is a normal glomerulus, and this is a glomerulus, normal and abnormal. This is the normal. All the glomeruli are good, normal. And this is the pattern of diffuse glomerular affection. Why diffuse? Because all the glomeruli is affected. And this is a focal glomerular affection because only 2 glomeruli are affected from 5. When taking the scene to the high power microscopy, I will see the each glomerulus. This is a totally normal glomerulus. This is a globally sclerotic glomerulus, and this is a segmentally sclerotic glomerulus. So this is focal, diffuse, global, and segmental. And this is by application. We can count here the glomeruli. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 10 glomeruli, and we have here 1 sclerosed glomerulus. So from the light power, I know that, okay, this specimen is sufficient. I have 9 glomeruli. I have 1 sclerosed glomerulus, which is maybe a normal finding in old age. So I know from the first that I have only 1 globally sclerosed glomerulus. This is a global sclerosis. I can see any histology of the glomerulus, not like this, not like this. Here I see dots of the nuclei, but here no, just eosinophilic material. I don't have any idea about it. So it's a globally sclerotic, but the change is focal or diffuse. It's a very, very focal. So from the low power, I can prescribe the pathology. And this is the other idea of the low power and other significance. This is a trichrome stain, as I mentioned before. So here, if I see the blue color, here it's the very minimal, it's mildly more than this. Oh, it's a moderate fibrosis. Here is a severe fibrosis. So from the first look to the low power, I can know that this patient is a very bad prognosis patient, and this patient is a good patient. Okay, this is how the low power help us to know the problem. Again, this again a severe form of fibrosis, moderate to severe. Okay, and again, those patients with fibrosis, more fibrosis, are not likely to improve even with treatment. And this is a very important idea to tell the patient about when diagnosing him for the first time. And this is the last section of the lecture. And as I mentioned from the first slide, this is the most important section in this lecture. So please get concentrated in this section. The spectrum of abnormal light microscopic glomerular morphology. So what's the meaning of this? What are the changes we are expecting to see in the light microscopy of the glomeruli? Why we'd like to know about that? Why? Because the histopathology is very related to the clinical presentation of the patient. Okay, so those are the spectrum of clinical manifestations which I can do biopsy for it, and this is the expected pattern I will find in pathology. I will not complete this slide now. I return to it back after discussing the next slides. This is the very important one. This is a diagrammatic representation of the normal glomerular capillary before seeing the how it's locked in the histopathology. If I suppose this is a glomerulus, okay, this is all as glomerulus. This is the proximal convoluted tubule. This is the juxtaglomerular apparatus, and within the glomerulus, those are the glomerular capillaries, all these are glomerular capillaries, and the glomerulus is surrounded by the Bowman's capsule. This Bowman's capsule, okay, and this is the glomerular capillaries. All the glomerular capillaries are joined through the mesangium. This violet color is the matrix or the mesangium, contain cells named the mesangial cells. So we here have mesangial cells, mesangium, and the glomerular capillaries. The blood come from here, so the filtrate come from here, and this is filtrated through the capillary membrane to the Bowman's space. This Bowman's space is named the urinary space. So all this white space is the urinary space. So here is urine, here is blood, and here is the filter. Within the glomerular capillary itself, the capillary itself is lined by endothelium, and from the outside by the podocytes, epithelial cell or the podocyte, and this is the endothelium, and this is the space for blood, and this is the space for the urine. If we try to enlarge or zoom in this glomerular capillary, it will be like this. This is the endothelial cell, and this is the podocyte, and this is the podocyte food processes, and this is the texture of the glomerular basement membrane, and this is the mesangial matrix and the mesangial cells between the glomerular capillaries. So we have the glomerular capillaries, the mesangial cells, mesangial matrix, Bowman's capsule, urinary space, blood space, proximal convoluted tubule, distal convoluted tubule. Why I'd like to discuss this, because all the renal diseases can affect these structures. So I may have a problem in the mesangial matrix. Maybe this mesangial matrix increase. Suppose if this mesangial matrix increase will compress the blood spaces, so by degrees, maybe mild, moderate, or severe. So any mesangial matrix increase or proliferation, which is called a proliferative lesion, or a proliferation of the mesangial matrix, will occlude the glomerular capillaries, and so subsequently, if the glomerular capillaries is occluded, so the patient will suffer from hypofiltration, or maybe if totally occluded, of no filtration, so the patient will come with anuria, renal failure, hypertension. Okay, this is how the histopathology will affect the presentation. If you'd like to see this mesangial cell, this mesangial cell is very few. If it's increased, it may occlude the mesangium and may increase and infiltrate the capillary and occlude the capillary, and again it can be a problem in the filtration. If I have a problem in the glomerular basement membrane, this is the site of filtration, so I will have a patient with clinical presentation of patient lose protein in urine, lose RBCs in urine, lose casts in urine. Why? Because this filtration barrier is affected. If I have a problem in the Bowman's capsule epithelial cells lining the Bowman's capsule, and have proliferation within this urinary space, it can occlude the urinary space, and again the patient will come with anuria. This is how it's very important to know about the histopathology. And this is nearly the same glomerulus, but by the light microscopic change. This is a proximal tubule, and those are the blood spaces. Those spaces are the capillaries. All these are capillaries. This pink color is the mesangium, and those are the mesangial cells. This is the Bowman's space. Here is the urinary space. Outside the capillary is urinary. Inside the capillary is blood space, and this is the juxtaglomerular apparatus. This to enlarge it again. Those are the filtration membranes of the capillary. This is the capillary membrane, and this is the capillary. This is the any white space outside the capillary is the urinary space, coalescent the Bowman's space. This is the Bowman's basement membrane, proximal convoluted tubule, and this is the mesangial matrix, and those are the mesangial cells. I'd like you to know this because all the disorders will be related to this. The last slide of normal before taking the abnormal is this one. Again, this enlarged one. This is the Bowman's capsule and this is the glomerular capillary, and this is glomeruli, and outside the glomerular capillary is a podocyte. This is a podocyte facing usually the urinary space, because the endothelial cell using the blood space, but podocytes usually face the urinary space. So return back to this, and this is why I asked you about the relation of the spectrum of light microscopic morphology with the clinical manifestation. So if I have a patient with asymptomatic hematuria or proteinuria, it may indicate that the problem may be in the filtration membrane, okay, or may be through the problem in the capillary space or the endothelium. There is a problem in the endothelium, this endothelium rupturing and excluding RPCs in the urine. So maybe histologically normal glomeruli. If I see if the problem is only in the filtration membrane, I can see with the light microscopic changes, or I can't see, okay, as I will discuss in the next slides. I will declare this issue. And maybe there is a problem in the capillary space or the capillary itself, focal or diffuse proliferation of glomerulonephrites. But acute nephritis means sure I should have a focal or diffuse proliferative or necrotizing glomerulonephritis. If I have rapid progressive renal failure, I will find the crescentic glomerulonephritis. If I have chronic nephritis or end-stage disease, sure I will found in the tissue diffuse sclerosis and glomerulonephritis. Again, I will describe these terms in the next few slides. Those are a very important terminology, is to know what's the meaning of focal, diffuse, segmental, global. We take it. Mesangial hypercellularity mean increase in these mesangial cells, as I told you. Endocapillary hypercellularity mean that there is inflammatory cells within the capillary or blood space, so it will occlude the blood space or may pass hematuria to the urine. Extracapillary hypercellularity means proliferation of cells outside the capillary. So the most important is the Bowman's capsule endothelium or lining endothelium proliferation, which will cause crescentic glomerulonephritis. I will describe some photos to you. Crescent fibrinoid necrosis, we can stop to here, crescent, okay. Those are the common histopathological finding you will find in the when you study the nephrology. We have the minimal change disease. From its name, we don't have any change in the light microscope. If we see the light microscope of the minimal change disease, we will see that it's a normal glomerulus. But this is the normal glomerulus. You see here, this is the electron microscopy of the glomerular capillary. This is the glomerular capillary, and this is the blood within the glomerular capillary, and this is the endothelium, and this is the glomerular basement membrane, and this is the podocyte food process. You see here the podocyte food process is very organized and arranged well, and they have slit membranes in between. Those are, and this is the urinary space, so this is a blood space, and this is the urinary space. Those are the podocyte food processes, and this is GBM, and this is the endothelium. This is the normal. You see here in the minimal change, you see those food processes is quietly arranged and very healthy. Here there is which is called food process effacement or coalescence of the food processes. We don't have a normal structure of the GBM, so you will find in the minimal changes that the main problem that the patient is presented with proteinuria. Proteinuria may be even nephrotic range proteinuria. Why? Because this manner of GBM will make the filtration barrier miss a lot of protein, and this is again fused food processes, unhealthy food processes. Those are the changes in the minimal change disease. So we cannot totally diagnose minimal change disease without doing electron microscopy. Minimal change disease means that there is no change in the light microscopy. We need electron microscopy to see that the podocyte food process is not that normal and arranged, but it's fused and will miss multiple proteins, and so you will study that the main clinical presentation of many changes is the proteinuria. Okay, this is the second type, focal segmental glomerulosclerosis. What's the type? What's the meaning of focal segmental? Segmental means segment of the glomerulus. So you see here capillary spaces, but in this part of the glomerulus, no spaces. It's all pink eosinophilic material. It representing glomerulosclerosis or fibrosis of this part, including the glomerular capillaries. This is very important pattern of you will find. Focal means that not all the glomeruli is affected, so are affected. So we cannot from this picture know that is focal or diffuse because it's only one glomerulus. We can judge here it's a segmental lesion. We don't know focal or diffuse. But here segmental fibrosis of the glomerulus. Again, here is the normal glomerulus. You see all the capillaries are open and wide. All the capillaries are open and wide. But here I have an area of obstructed, occluded glomerulus. And sure, the presentation of the focal segmental just only one part of the glomerulus, so the presentation will be more insidious. So we will find that the focal segmental give a reduction of the GFR over years, renal failure over years, hypertension over years, but the main presentation is a slight renal impairment, hypertension, maybe proteinuria from the occluded or the fibrotic segment, but not heavy proteinuria. You will find this is the main clinical presentation of focal segmental glomerulosclerosis. Again, here, if you see here the normal, the capillary membrane is very, very thin and is like the pencil writing. But here you see the capillary membrane is a lipstick, not a pencil. And we can't find any other abnormality in the number of cells. The number of cells is the same, but only the membrane is thickened and disordered. And again, this as a minimal change. This is why the membranous glomerulonephritis is mainly presented by proteinuria and massive proteinuria. You will find that the renal impairment and the deterioration of GFR is late in the membranous. The main presentation will be the proteinuria and nephrotic syndrome. This is another type of the membrane change accompanied by another change. So here you will see here there is no capillary spaces. Why there is no capillary space? Very few capillary spaces. Why? Because there is a proliferation of the membrane, proliferation of the cells. The cells is too numerous, occluding most of the spaces, occluding most of the white spaces, and the mesangium is also increased. This is sure a hematoxylin and eosin picture because we only see cells. You here will find cells only cells. Spaces is very few. Sure, this patient will be presented with renal impairment and the deterioration of kidney function. Sure. And oliguria, maybe anuria. Why? Because there is no spaces for filtration. So the membranoproliferative is a form of acute nephritis which will be accompanied mainly by the oliguria, hypertension, renal impairment. Why? Because this proliferation occluded the spaces of the filtration. And this is another explanation of the hypercellularity. Hypercellularity may be proliferative multiplication of the glomerular cells in the mesangium, or may be exudative by multiplication of inflammatory cells within the capillary itself. And this is the difference. So proliferative means that the normal glomerular cells increased. Those are normal but increased, like the mesangial cells or endothelial cells. But here the exudative means that abnormal cells like inflammatory cells, lymphocytes, monocytes, macrophage come to the glomerulus and occupy the capillary space, but the result is the same, is the deterioration of the function and the hypertension and the hematuria. And this exudative, what of the most common causes is the post-infectious glomerulonephritis, post-streptococcal glomerulonephritis. This is a severe form of proliferation. Proliferation of the Bowman's space epithelium cause, which is called crescentic glomerulonephritis. And this crescentic glomerulonephritis is a total obstruction or a great obstruction of the urinary space. The patient will be anuric, no filtration at all, and we will find the patient deteriorated kidney function within a very short time. And this is why the patient is deteriorated, because as you see here, no urinary space at all. This one endothelial layer of the Bowman's capsule replicated to 10 or maybe more than rows will occlude the urinary space. At the end of the lecture, I hope, I know it's a difficult topic, I hope you get the message. The most important message I'd like to highlight, that you should, before studying the disease of the kidney, know about the histopathology, because the histopathology will affect the clinical presentation of the patient and will affect the management of the patient. Thank you and goodbye.